Jackson, if you're talking to us, you're muted.
Oh, I'm so sorry. I was testing myself because sometimes I forget some of this stuff. Awesome, guys. So now it is 2:10. We're gonna get started now. So I have this wonderful wheel right here. I think you guys can still see my picture. I put all your input names here, so whoever comes up on, you guys are gonna tell me your normal values. So let's do this. Okay. The wheel is now spinning. Awesome, Soraya. So can you tell me the normal values for potassium?
They are 3.5 to 5.
Correct, 3.5 to 5. Awesome, and that number is usually solid. So obviously anything lower will be hypo, anything higher than that will be hyper, okay? Both of them will lead to EKG changes. That's something you guys have to know by heart. With the increase in potassium, you guys will get an increased risk for STEMIs. The reason why is you'll have the little jump up. Okay, a STEMI is really easy to see. Once again, this is not your level where you need to understand EKGs and all that good stuff. Once you get into intermediate med surg, however, you do need to understand that hyperkalemia will cause an EKG spike. Okay, your heart will just spike up. Okay. On the other hand, hypokalemia is also very bad for you. So that's why we always have to keep it within that range. However, it will manifest in a different way. It usually manifests in an inverted U wave. So yeah, that's something for you guys to know. Something to keep in mind in. But those are your normal levels, and it's always going to be like that, 3.5 to 5. Okay. Next up, we have. Sorry, I love the wheel. It's just so fun. Awesome. So, Crystal, can you tell me the normal values of sodium?
135 to 145.
Awesome. And honestly, that's one of the easiest ones to remember. But like, I mean, there's only like one difference sometimes I see, like 135 to 146. But other than that, I mean, that's your normal range. It's going to be the same as your pH range, just replace the 1 with the 7. With sodium, the thing you have to know with every single time you know about sodium is that it's going to cause neurological defects, okay? So a lot of your neurological concepts are going to be very like, oh, they're going to be lethargic, or they're going to be irritable, or they're going to have an increased risk for seizures. So those are some things you need to know about sodium. And I'm going to associate a lot of these things with organs because it's easier to see with organs. So once again, potassium's all about the heart, sodium's all about the brain. Cool. So now we're going to go next. Awesome. Punette, can you tell me the calcium levels? Feel free to write in the chat as well. Not a big deal. It's okay if you don't know. You can also put you don't know. It's not the end of the world. That's we're all here to learn. Yes, no, maybe so. Punette, yes. Perfect. Yes, yeah, no worries. You're good. Honestly, yeah. So that's actually one of the normal levels. So with calcium, the lowest I've ever seen was 8.5. Don't worry about it. So it's gonna be from 8.5 is usually the lowest I've ever seen it, and the highest I've ever seen is 10.5. Once again, each book is different, but I usually take the lowest, and then I usually take the highest, and that's gonna be related to your calcium. Okay, calcium, once again, it's related to your bones, but don't associate it with your bones because it's one of the many functions of calcium. What you want to associate it with is muscle, okay? And so a heart is also a muscle, which then it can affect the heart as well. But calcium is very essential to the muscle, okay? If you guys remember from physiology, you remember the myosin and trypsin? There's the calcium molecules within those, okay? If you have more calcium, it means that you won't be able to move as much. If you have less calcium, then you're gonna be moving way too much, okay? And that system is called tetany, okay? Tetany. Okay, so associate calcium with muscle defects, okay? So these are gonna be your signs and symptoms where you're gonna be like, oh, 100%, I know that one right away, okay? So that's why if you have an increase of calcium, you will have very like rigid muscles and you won't be able to move, and you're gonna be fatigued that way. Versus the other side is going to be, if you have too low of calcium, then you're moving way too much, causing tetany, all your muscle spasming. That's going to cause fatigue in that way, okay? Does anybody have questions between potassium and calcium? Okay, so remember to associate, okay.
Question on the calcium. I read but I couldn't understand what's the difference between ionized and not ionized calcium.
Ionized calcium versus ooh, that's a good question. I actually don't know the difference between ionized calcium versus
Because there were the ranges were different too. When it was ionized, I think it was the 4.5 to 5.1.
Mm-hmm.
And then right now that they gave the 8.5 to 10.5.
Oh, that's interesting.
So I asked the professor just to make sure.
Oh, that's a good question. I feel like that's a very specific question in the sense of like we usually don't use the ionized values. We usually only have one calcium value, and it's usually drawn through the blood. I'm assuming that that's a little bit more specific in like nutritional area, but I've only met like calcium this way.
So then you've only been tested on the regular 8.5
Yeah.
through. Okay, perfect. So let me cross that out. Thank
Yeah,
you.
of course. You've only been tested on the regular. Usually professors do not test on the other one because it's technically not used. When you see on patients' lab reports in the charts, you'll always see them have the regular like calcium ones. Okay, awesome. Now we have magnesium, so go ahead. Awesome. Laura, can you tell me the normal levels for magnesium?
1.3 to 2.1.
Yeah, that's the one I memorized. Honestly, it's the weirdest one out of all the four. But yes, once again, yeah, magnesium is definitely 1.3 to 2.1, okay? Understanding your inverse relationships is going to be very important, guys. So with calcium and magnesium, if one goes up, the other one will also go up, okay? They're just the same. They're always going to go up that way. They're going to have an inverse, calcium's going to have an inverse relationship with phosphorus. So if you have more phosphorus, it means you're going to have lower calcium. Does that make sense, guys? So those are your inverse relationships. Potassium and sodium will also be inverse of each other. So if one is high, the other one will be low. The only event that that you will have those discrepancies, whereas it's like both of them will be high, is in kidney diseases, okay? Like chronic kidney diseases and usually end-stage kidney diseases, everything's just high because no one's getting rid of anything. And so that's really why you have to manage that. And that's what we'll see a lot. So if you guys understand this, with magnesium, you have to understand that if it's really high, it's going to cause something called the tortoise de pointes, which is another EKG term where it's just like it bounces around. Tortoise de pointes means pointy mountains. So what you're going to see in the EKG is very like pointy, twisty mountains. Oh, never mind. It's twisty mountains. But yes, magnesium is going to be one of those other ones, and so associated with each other. With basically that said, with lower calcium means there's going to be lower magnesium. And so those levels are going to be the same. Okay. Yeah. Cool. Any questions so far? No, right? Awesome. Last but not least, we have phosphate. Yeah, phosphorus. Awesome. Megan, can you tell me the normal levels for phosphorus? Or phosphate? Megan? Yes, no, maybe so. Are you there? You ready to write it in the chat as well?
I'm so sorry. Hang on.
Of course, don't worry.
$2.5 to $4.5.
Yep, that's always, I've seen it like
Oh,
that.
shoot.
It's pretty much like that. Once again, we need to know that phosphorus is a bit on the acidic side. So that's why your patients who are very, who have chronic kidney failure, they tend to erode themselves because of the phosphorus being so acidic. With that said, acidity, when talking about acidity, it's really nice to know that potassium is another acid, okay, guys? So if you have a buildup of potassium in your body, it means you're definitely having an acid reflux. So metabolic acidosis. Phosphorus is the other one that will be also acidic. Majority of the other ones will not have an alkaline or base laying. Just know that potassium, phosphate seem to be the most. The last one is usually chloride, guys. So chloride is also another acid. I mean, the normal levels for it, I've seen like 96 to 100. And what was it? 100 and like honestly, it's 106 and it would be fine. But that's how I memorized it. But chloride is another acid, okay? So your three acids, if you have an increase of any of these, you're definitely gonna have metabolic acidosis, okay? And you guys learned all about metabolic acidosis fundamentals. It's just gonna constantly be reviewing if you guys know this, okay? Other than that, is there any questions about our warm-up today, okay? Any questions, concerns? No?
Jackson,
Yeah.
sorry. You mentioned the inverse relationships between calcium and phosphate. Can you repeat that? Because
Of
I
course.
heard of the low calcium means low magnesium. What did you say about the calcium and phosphate?
So calcium and phosphate will be inverse each other. If one is high, the other one will be low. So in the event in case of phosphate being high, calcium will be low, and then vice versa. If calcium's high, phosphate will be low.
Oh, okay, got it. Thank you.
Of course, yeah. So your kidneys will always be responsible for basically kicking somebody out. For example, if you have too much potassium, they'll increase sodium to try to get out the potassium. It's a very interesting thing. Cool. Awesome. So I'm going to move on to answering questions today. Other than that, let me see. Perfect. Oh, okay, cool. Awesome. So this week, you guys are talking about GU system, guys. The GU system is a pretty interesting system to talk about. It's just, if your kidneys fail, then every part of your body fails, and it's really bad. But with that said, I'm going to see, let's see. I think Crystal put this up. Oh, no, it was Planette. Thank you, Planette. So we're going to talk about urinary and renal and electrolyte imbalances. That's a lot of that's a lot of stuff to talk about. But urinary and renal kidney systems as well as balances. So when we're talking about the renal system, guys, do you guys know the basic renal functions? Okay, we're talking about acid-base balances. We're talking about fluid electrolyte balances, as we talked about earlier. So any fluid, if you have hypovolemia or hypervolemia, is usually because of the kidney system. Also, remember this fact, guys. Kidneys is responsible for making erythropoietin. What is erythropoietin?
Blood
Making
blood.
red blood
Yeah,
cells.
good.
The red
Exactly. Never forget that, because it's gonna follow you back, and you're gonna wonder why a baby would have so much red blood cells. Okay, it's because the kidneys are responsible for making that. Okay, erythropoietin. Other responsibilities of your kidneys are going to be related to so let me see. Yep, fluid electrolyte, acid-base balances. Also, it's responsible for cleaning up your blood. We're getting rid of the toxic waste there. So in case of a buildup, we want to get rid of it. We also, the GU system in general will also help to decrease the risk of UTIs. That's why we always emphasize to our patient, make sure you're drinking a lot of water, because once you pee out, then the bacteria gets flushed out with it, okay? And so I'm trying to figure out, is there any other ones? Does anybody else have other functions of the kidneys? Feel free to let me know.
I'm sorry, what was your question?
So functions of the kidneys other than the ones I've mentioned. If not, it's okay. Don't worry. I'm just going to open my notes to make sure that I got those. I got all the big ones, you know.
Was it I could be wrong, but like regulate the, oh my god, what is it called? RGBs or RBGs? Shoot.
RBGs.
The blood gases in the blood.
Blood gases. Yes, you can also regulate all the blood gases in the blood. So we're talking about they usually do it between the that's acid-base imbalances, so it's HCO3, as well as potassium, to get rid of both of them, versus the opposite of it. Cool, yeah. So hopefully that is basically all the ones that are very pertinent to the ones I remember. But with that said, feel free to study it. It's all about patho, it's all about physiology, and if you guys understand normal functioning. So with that said, guys, we have a lot of deficiencies within electrolyte imbalances, okay? When we talk about fluid imbalances, it's usually because of the fact that you're keeping too much sodium, or you are basically removing too much sodium. If you keep too much sodium, then it means that you're going to be more likely to increase your water intake, which causes hypervolemia. And with that said, if you lose too much sodium, then you're going to lose a lot of water, which means you're going to be hypovolemic. In children, it's very bad, guys. As we know, children are like 30% water-based, so we don't want them to be dehydrated. But it's also the same for geriatric patients. We don't want them to be dehydrated because it can lead to increased risk of all these wonderful things that we all know about, like UTIs and really dry skin, and we don't want that. With that said, you have to understand that there's a difference between hyponatremia and all the volemics. So natremia occurs separately from the volemia. It can cause each other. However, they occur separately. What do I mean by that? It means that in event that, for example, you're hypervolemic, but you can actually be hyponatremic. It's a very interesting concept when we have to talk about it. It's just the start of that disease just happens to manifest that way. But in the sense of theoretically and how we're supposed to do it, hypervolemia tends to be the fact that you have too much sodium, versus hyponatremia is going to cause the reduction of water intake. So it's all about your kidneys function able to remove or keep the sodium. Okay. Remember the potassium is usually just for usage of the acid-base balances, but sodium is your key finder for volume, fluid electrolyte. Okay. So in the sense of all these wonderful things that we talked about, we know that hyperkalemia, or also known as hyperpotassium, guys, is going to be greater than 5. Okay. Like I said, knowing that the peak T waves, okay, like I said, those STEMI waves, if you're talking about EKG, they're going to be super peaked. As a result, you have an increased risk for a heart attack or a STEMI. Okay, those stuff, pretend that you didn't learn that stuff from me, but it's going to be covered later in the lecture. What you're going to need to know is that you're going to have nausea, you're going to have cramping, muscle weakness, and then a lot of heart defects, as well as some bradycardia. Okay, guys, so that's going to be a lot of the potassium manifestations for hyper. Okay. Obviously, the best treatment, guys. Best treatment for it is we're going to usually do one of 3 things. So we're going to do calcium chloride. It's basically calcium helps control the muscle. As we know, like calcium channel blockers, it helps control that. Oh my God, I didn't scroll down. Anyway, so yes, so calcium can be in charge of the muscle. And we know that the heart is a muscle, so it's going to try to slow it down. Like in this case of calcium channel blockers, it's going to try to slow down the heart. Okay. With that said, we have chloride, and chloride is going to help to balance that out a little bit. On the other side with sodium and all that good stuff. I don't really remember how that one works, but it's a rapid treatment. You usually push them with calcium chloride first. Next, we use albuterol, and the reason why is that albuterol helps to bronchodilate, and we all know that. But albuterol basically helps to push more potassium back into the cell, and so by pushing more potassium back into the cell, that's kind of what we want. And so that's why we use albuterol. And finally, the last one is, hang on with me, guys. This is going to be a little bit crazy. Majority of professors like to test this one, but it's regular insulin. So why are we doing insulin? Okay, we know the purpose of insulin. Insulin, as we learned with diabetes, insulin is the purpose of basically making sure the cell uptakes more glucose. Okay, that's what it is. Like it releases basically cell to cell. Oh, you need to take in more glucose. Great. So how does that help with our situation of hyperpotassium? Well, what happens is when you open up your cell is not only taking in glucose, but it's also taking in certain electrolytes. One of those electrolytes tend to be potassium, okay? Potassium loves to go inside the cell. It's where it loves to live. All potassium likes to be inside the cell, as you learn from physiology. With that said, once the insulin activates, glucose gets drawn in, and then potassium gets drawn in, okay? Those two are going to be drawn in. But with that said, what happens if your glucose is too low? We go into hypoglycemia. And as you guys know, hypoglycemia is not something we want our patient to be in. So at the same time where you're pushing in the insulin, you need to back it up with a D50, okay? A D50 is one of your normal ones that you kind of know, but D50 is dextrose 5 with water. So dextrose is something sugar water, okay? So we make sure that we have that laying patent. So then when we're pushing our patient, then there's like no discrepancies within hypoglycemic control. So in the sense of we don't want them to crash and cause hypoglycemia, neurological or adrenal hypoglycemia, okay? So that's why we have to make sure they're on dextrose. And in the sense of, we'll also back it up with sodium bicarb, guys. So the reason why we do that is, remember, I said earlier that potassium is acidic, okay? It's going to cause metabolic acidosis. So if there's metabolic acidosis, we need to treat that acidosis, okay? And the best way to treat it is sodium bicarb, okay? Why? Once again, sodium and potassium have inverse relationships to each other. Sodium will drive all the potassium back into the cell, which is what we want, which then decreases the acidosis, and bicarb. Bicarb is the opposite of HCO3. Oh, sorry. Bicarb is the opposite of the H hydrogen bond, and will basically start to combine with all the H's to decrease the acidosis of the bond. Does that make sense? Does anybody have any questions about what I just went through? Because there's a lot about patho. questions, concerns? No, let me know in chat box as well. LOL, no questions. Perfect. Awesome. Yes, honestly, it's very complicated to understand. But once you guys kind of get like the rhythm of it, like you guys will be like, oh, that's how I need to think as a nurse. It's just right now you guys are trying to learn how to do that, but it takes time. Trust me, it takes time. But this is, I'm trying to explain it to you so then you guys can always build on top of it. So yes, so that's why you do those treatments. Cool. Okay. Now we have it on the opposite end of the spectrum. We have hypokalemia, also known as hypopotassium, guys. So once again, the opposite, we have some, which is basically weakness, paralysis, lethargy, and muscle cramping. Okay, guys. So it's those things that I would love to explain, but we don't have a lot of time to do it. So it's sometimes it's important, sometimes it's not. It really depends on your professor if they're gonna be like really bad about it, and they're gonna be like, select all apply, choose all your questions related to hypokalemia, which is a fair answer for them to ask, a fair question for them to ask. However, it's just like, anyway. With that said, in the EKG, it's usually all potassium questions are all about EKGs. You're gonna have an inverted U wave. So what in the sense of basically absent T wave with a U wave. Okay, so where the T wave is supposed to be, it's gonna be a U wave instead. Okay, that's for you to know for later in the future. If you guys see that, but I don't think she's gonna test you guys too tough on that. Okay, so they used to talk about that. But how do you do it? So since we're low on potassium, what's our best option? To increase potassium, okay? Number one is usually to do it through diet, but if they're like critically low, guys, we might have to go with potassium chloride, okay? Once again, remember that I said potassium was acidotic, okay? What is your body gonna actually be in? Metabolic alkalosis, okay? We wanna fix that problem, okay? So the first thing we're gonna do is potassium chloride, okay, guys? We're gonna do a push of potassium chloride. We know why potassium's there. We want more potassium so then it increases stuff. But we also do the chloride part because then chloride can also work as a acid electrolyte, okay? So it's gonna help to raise that blood pressure, raise that alkalytic level to a higher level, okay? To basically normalize everything. So our first option is always to use potassium chloride. Know that it is a slow push, okay? The reason is potassium is acidic, okay? We don't want to push like, oh, let's push all of that in. We want to do it at a slow push, and as all medications do, slow pushes are usually over a minute. I've seen in nursing practice that you guys can do it over 5 minutes, just to be on the safe side. But according to ATI book, usually a minute is fine. Just pushing it over a minute, you'll be fine. The thing is, it can lead to corrosis or the like skin burning, okay? So that's one of the big things you guys have to know. And then you can draw back and push it back into veins, pretty much, yeah. Obviously, you guys can do other things to reduce the pain. If patients are feeling pain, make sure they're having ice packs and some pain medication. Yeah. So another big thing is that potassium and magnesium have a relationship to each other, and they're related to being the same. So if potassium's low, magnesium would be low, okay? And so you have to also monitor the signs and symptoms of magnesium. Cool. Awesome. Any questions about potassium in general? Let me know. I know I said a lot. Awesome. Good. Awesome. So I'm going to continue on to the next one, guys. So like I said, sodium. Sodium is all about the brain. So all your signs and symptoms are going to be related to lethargy or irritability or seizures. And so those are kind of things to help you guys kind of know it. So with hypernatremia, that means an increase in all the wonderful sodium that we have in our body, okay? So that's going to be increasing in lethargy, with seizures, coma, muscle weakness, and polyuria. And we understand why polyuria, right, guys? Because like I said, sodium is going to draw more water with it. And so if our kidneys are working really hard to get rid of that sodium, majority of our water are going to be out. So we got to make sure we back it up with more fluid, okay? And so when we talk about fluid, guys, we have to replace it with water so replace it with all our bagged fluid, okay? This is where your tonic solutions are going to come in, okay? Majority of the time, doctors are never going to order hypertonic solutions just because it's too much sodium. But majority of the time you have ISO. Do you guys know what are the 3 ISO solutions?
Lactated ringers.
Good.
D5W.
D5W and?
Regular saline?
Oh, regular saline.
Regular saline at what point?
Is it 0.9?
Good. Okay, so memorize that, guys. If you guys memorize anything for rest of nursing school, know that normal saline 0.9 is normal. Okay. Lactated ringers, that's normal, and the 550W is all normal. Those are your 3 key normal ones. You're never gonna like do something else other than that. Okay, guys. So obviously, for example, guys, if I do normal saline at 3.0%, what type of solution would that be?
Hypertonic?
Yes, a hypertonic solution. You have more solutes than you do with water, okay? So your patient will, if you put this in your patient, it's going to be dehydrating your patient really quickly, okay? In the event of normal saline with, let's say, 0.2, okay? What would that be?
Hypotonic?
Hypotonic, perfect, the opposite, where the solutes are basically too small, but the water concentration is really high. Cool. When we talked about that, and then so remember this normal saline 0.9 is your normal. If they put anything other than that, it means you have to figure out, is it hypertonic or hypotonic, okay? In the sense of, for example, sometimes you're gonna run into something called D5W. Your doctor's gonna order D5W with normal saline at 0.9. Sometimes doctors do that because you have to consider the glucose side of it as well as the fluid electrolyte imbalance side of it. But what is this combination considered? Is it hyper or hypo? Or is it normal? ISO. Yes, Crystal, you wanted to say something?
I think it would be ISO because they were both neutral.
Ooh, it's a trick question, but thank you so much for expressing it. Yes, honestly, at first I thought it was ISO too, but the reason why it's not ISO is that now you're combining a normal plus a normal, which both have normal solutes. When you combine both solutes, it's actually considered a hypertonic solution. Does that make sense?
Yeah, I was thinking too, but they're both natural.
Yeah, so even though they're both isotonic, guys, or normal.
Times 2 to the second power, I guess.
Exactly. It's kind of like 2 to the second power. I agree with that. Yeah, so what you do end up doing is you basically overload your patient with too much solutes. Okay, so usually your doctor will order a lower form of sodium just to balance it out. So that's really what we have to monitor out. But the majority of the time, your 3 normals, your 3 isotonic solutions are normal saline, 0.9%, lactated ringers, which is used in pregnant women. Okay, you guys will learn about that in OB, but majority of the time is pregnant women, lactated ringers, and then D5W for anybody who has sugar intolerance or needs excess sugar. Okay, so those are your 3. When we're talking about hypernatremia, guys, what do you guys think? Should we give them a hypotonic solution, an isotonic solution, or a hypertonic solution? Hypo. Good. That's a really good guess. I also thought about that too. So majority of the time, your doctor will actually order an isotonic solution. Okay. The reason why is that we have to compensate for if there's too much water, then our body's not going to be able to filter out that excess sodium. And so it's going to actually cause a fluid overload in your patient, and we don't want that fluid overload in a hypernatremic patient. So majority of the time, your doctor will just order an isotonic solution. And so, yes, thank you so much for your input on that, but I hope you understand why we have to do an isotonic solution over a hypotonic solution. So with that said, guys, the big thing, if you're ever going to do solutions and your patient has sodium imbalances, please, please, please do a slow push, okay? Any side, like if it's even low or if it's high, do a slow push. The reason why is, let's go back to physiology when we talk about the sodium-potassium pump, okay? If we do a slow push, the body will be able to adjust to it. If we do a fast push, what's going to end up happening is that that sodium chain will then become all over the place, and it's going to quickly cause neurological injury, okay? We'll know neurological injury related to LOCs, okay? So if your patient could tell you, oh, I'm at the hospital, but after you did that push, they say, oh, I'm at home, that's a key sign of concern, okay? So always with fluid, anything related to fluid, make sure it's a slow push, okay? I'm saying it's like, don't anything like at least 100 per hour, you'll be fine. But do a slow push, okay? because it's going to cause cerebral edema, which then leads to neurological injury. And the last thing we want to do is hurt our patient. Yes. Megan?
Would it also affect the heart?
In the sense of it has a possibility to affect the heart, but it's going to affect your brain much more because your brain is highly fluid. We were talking about the cerebral fluid. So your heart is not necessarily in the fluid. It helps regulate the fluid, but your brain is surrounded by fluid, which is why we say the brain is going to affect sodium more. Does that make sense?
Yes, because of the cerebral fluid.
Yeah,
The brain is floating in the
water. Yeah, exactly. And so that's why brain is so associated with sodium fluids. Okay, that's why we don't want to cause it, and we want to do it slow, because if we do it way too fast, our cells can actually burst, and that's what causes that concept. Okay, so yeah, if you guys understand the normal, like sodium goes out of the cell if in the sense of like there's too much fluid on the outside and we want to balance it out, so sodium goes outside the cell. But if there's too much sodium in the cell, sodium's going to try to get into the cell just to balance it out again. Okay, that's why if you guys remember from what is it, biology? I feel like this is a biology concept where it's just like if you input fluid in, if you put a cell in an isotonic solution, in hypertonic solution, it will start to basically shrink because all the water left it. And then in a hypotonic solution, it will start to grow super big because all the water is trying to get into the cell because all the sodium's there. So it's the same concept, guys. Okay.
What was the name, like the names again of like cells shrinking and cells bursting?
I just know it related to the theory of osmolarity, and I don't remember. I just know.
Okay, no worries.
Yeah.
Wasn't it lysine?
Oh, yeah, cell death,
Lice, yeah. So it really depends on where it is on the spectrum. Also, you have spell bursting, which is really bad. Anyway, that's hypernatremia. Is there any questions about hypernatremia? No? Yes? No? Awesome. Oh, yes.
I was gonna say no.
Okay, cool. Thank you, Crystal. On the other hand, we have hyponatremia, guys. Once again, big keys and signs symptom is they're going to be more prone to disorientation as well as irritability, okay? So versus the other one where they're lethargic and they're not alert, hyponatremia tends to be more irritable and they're disoriented, okay? They're also going to have nausea and vomiting, but a lot of things have nausea and vomiting. But they also have a risk for seizure, but both of these have a risk for seizures. So that's really different. So hypernatremia, you have lethargy, increased risk for coma, so you're like totally knocked out. Hyponatremia is going to be for disorientation and irritability, okay? It makes sense, though, when you talk about hypernatremia being that way. Remember when we talked about the cells, your brain cell in a hypertonic solution will then result in shrinking. And so if it's a shrunken brain cell, it's not going to do a lot. In the sense of the other one, you'll still be alert, but your cells are super enlarged. So then you're going to be a little bit more irritable and you're going to be a little bit more confused. So that's going to be the best way to just explain it. But once again, for hyponatremia, you guys have to treat the cause of it, okay? Whatever caused it. So with that said, hyponatremia means low sodium. What are some conditions that cause low sodium that we have learned? Anything that's hypervolemic. So in a hypervolemic situation, we give, like, for example, if you give hypotonic solutions, it will cause a hyponatremic reaction, and then that's going to result in that. So then we have to fix that, and so it's very careful that we have to balance both sides of the world. So yeah, also replace sodium carefully, as we talked about. Slow drips, guys. Slow drips, slow drainage, just for these patients who have sodium deficiencies. Okay. Obviously, the low end stuff that we have to do: restrict sodium, increase sodium intake, etc., etc. Those are like basic nursing skills. So yeah. Any questions about sodium or potassium at this point, guys? No, yes, no? Awesome. Okay, cool. So I'm going to move on to the next one, guys. So calcium. Calcium is another big one, guys. Like I said, calcium is related to muscle, okay? When we talk about muscle, all those wonderful things. And so hypercalcemia means a lot of calcium molecules are in your entire body. It's going to basically cause muscle rigidity, or basically hard to move your muscles. Okay, there's so much calcium in your body, you can't move it. Okay, And so that's going to be why you're going to have that muscle rigidity. That's why you're going to have plasticity. That's going to be common where you have plasticity. You're also going to have polyuria and polydipsia, but that's because a majority of these things you need water to balance it out. So our body's going to try to pee it out, and the kidney's just trying to do its job, which is why you're going to be peeing a lot. Okay, a lot of hyper conditions, you're going to be trying to pee a lot just because of that reason. With that said, so plasticity and lethargy are going to be your biggest kind of sign and symptoms. If you know your patient is like, oh, they're squeezing very like weak, there's something wrong, and maybe you need to check that their calcium levels. Is it low? Is it high? If it's high, that means that's something to report to the doctor. Okay, and so when we talk about when would you have hyperkalemia, if it's increased release from the bone. Okay. Calcium is stored in the bone. So if you have an increase, like something breaking down your bone, or you had a bone injury, then you're going to release so much calcium into the blood that causes calcemia. Okay, like last week we talked about bone injury and we talked about fractures. When you have a fracture, you have an increased risk for fat embolism, but you also have an increased risk of breaking all that calcium that you stored there into the blood. And so that's going to be another risk for hyperkalemia, guys. So yes, everything kind of blends in together if you kind of know that. Hyperparathyroidism is another one. And this one a little bit too adept because I don't think you guys learn endocrine system at this point. You guys will learn endocrine system in intermediate med surg. But parathyroid hormone is responsible for basically the breakdown of bone. And so if you have hyperparathyroidism, it's breaking down way too much bone, which is why you have so much calcium. Okay. On the other hand, if you have decreased excretion, so if you can't excrete the calcium, then it's going to build up. Okay. And this is going to be in your kidney diseases. Okay. It's honestly, when you guys try to figure out, this is the best way to memorize this stuff. It's just trying to figure out like, oh, that's the patho. What am I going to see in it? Okay. And so that's going to be able to help you guys understand it. With that said, treatment options, we're going to do IV fluids, like we said, usually isotonics. Diuretics, okay? We don't want to always do diuretics because we know the benefit, like the risk factors of diuretics, but it can help to treat any extreme cases. It's usually in the extreme cases, like for example, in potassium, where it's just like, oh my God, maybe I need to like get rid of all that potassium, pee it out. Diuretics are usually the best way for emergency situation, okay? Corticosteroids, okay? The reason why you do corticosteroids is, once again, it decreases vitamin D, okay? So what happens is that, oh, I forgot this one. The renal system is also responsible for converting stuff to active vitamin D. So thank you for so much, Panette, for that. Oh, I almost forgot about that. So if you have too much vitamin D in your body, then you're going to absorb much more calcium in the GI tract, guys. And so with that said, we want to decrease vitamin D, so you usually use corticosteroids, okay? And corticosteroids will activate the fight or flight response, okay? And that means you're not going to rest and digest, okay? Your body's not going to try to make vitamin D. It's going to try to basically increase your blood pressure. It's going to try to do inflammatory responses, okay? So that's why we do that medication. Obviously, reduce vitamin D intake. And then phosphates, okay? Sometimes you talk about phosphate binders. Phosphate binders can help with this, guys. And it's a type of medication that you guys will learn later in intermediate methods, but technically not commonly tested. But that's pretty much it for that one. So phosphate binders bind to calcium. And as we know, if phosphate is high, calcium will become lower, okay? So we'll try to compensate it by using phosphate to compensate for the potassium, for the calcium, okay? And then with that said, we have hypokalemia, which is on the other side. Like I talked about, on this side, it means that there's low calcium, guys. When you have low calcium, it means your body's moving, okay? It's like there's nothing to stop it. So tetany is a key sign and symptom. Chavoxy sign and Tresvaux sign, okay? Chavoxy, remember, is for cheek. So C for cheek. So if you check the cheeks, it's like it really moves really quickly. And then Chavoxy sign is going to be about the little Trousseau sign. So remember, if you guys are going to perform a procedure on it, make sure you put a blood cup on them, okay? And then tighten it all the way to like probably 200, okay? Keep it there. Don't even release air, guys. You're not supposed to. And then wait for a few minutes. And what you should see is your lower half of the hand starts to twitch and has a T shape here. I like to call it a T shape, but that's Chavoxy sign. So once again, the reason why is because it's just going to be super active, okay? Calcium, if you don't have calcium, then you're just going to be super active. Cool. It's going to cause fatigue and lethargy that way, just because of the fact that you're like, I'm so tired from moving around so much. So that's going to be related to that. So what are our treatment options for calcium? It's going to be calcium chloride. Okay, once again, reason why calcium chloride, calcium, just increase more calcium, okay? Majority of the time, the chloride in this situation will attach to this the sodium, so it makes salt, so your body becomes a little bit more salt water. Yeah. And then calcium glutamate is another type of medication you guys can give. And then cardiac monitoring. Cool. Obviously, you cardiac monitor just in case, because the heart is still a muscle. Okay. Other than that, is there any question about calcium specifically? No, yes, maybe so. Explain. Let me know. I'm always here to explain it for y'all. No questions. Perfect. Thank you, Soraya. With that said, we're going to move on to magnesium. So the next two are not commonly tested at this level, but they could be. I don't really know how Professor Garcia goes over it. But magnesium phosphate seems to not be tested at this level just because of the fact that your main electrolytes, your three main electrolytes that you're always going to be dealing with is potassium, sodium, and calcium. Magnesium phosphate do not tend to be tested out a lot unless you're talking about chronic kidney failure. When you talk about chronic kidney failure, you're going to look at that potassium. But other than that, majority of the time, you're not going to talk about those two. But magnesium, once again, we talked about hyper being above 2.1. Yes, 2.1. And so we talked about neuromuscular, cardiac depression, drowsiness. The thing with magnesium, if you have to understand the deep tending reflexes. So the reflexes are going to be decreased in a magnesium state, okay? It also will decrease your respiratory rate. Those are big key things that you have to watch out for. And so what we do is usually we do saline, diuretics, hemodialysis. Hemodialysis usually fixes a lot of things because hemodialysis is just kidney failure. And it's just trying to fix what kidneys usually do. And so, yeah, that's why you only see these conditions in all those renal failure patients, majority of the time. And then on the other hand, we have hypomagnesemia. Like I talked about, if magnesium is low, calcium is also going to be low. It's just they're the same. So if you're looking at low calcium, we're looking at Chbosky sign, tetany, and Trousseau sign. Okay, always just associated with that. In addition to that, you're also going to have tortoise pointus, which I talked about, twisting of peaks, which is really abnormal and it's super weird. And so you'll know when you see it. I wish there was a picture option here, guys. I can show you. Actually, I'll show you here right here. So I'm going to share my entire screen. Cool. Perfect. And so this is what it looks like, guys. Tortoise pointus is just up and down, up and down, up and down. It's really twisty, and you guys can see the little, yeah, you guys can see how abnormal it looks like, because an EKG should not look like that, okay? Also, just want to talk about those TikTokers who like do that that EKG. They cannot draw an EKG to save your life. It always bugged me. Anyway, this is a side note. Phosphate, once again, it's acidic, so we also have to manifest the all that good side. So hyperphosphatemia is talking about a lot of phosphate in the blood, and so what you're gonna see is hypokalemia, guys. So what are in hypokalemia is basically in hyperphosphatemia, okay? Phosphatemia, okay? So you're gonna see tetany, you're gonna see Chbosky, you're gonna see serosines, you're gonna see they're tired or they're lethargic because of that reason. And so, yeah, you're going to get phosphate restrictions. Make sure that you're eating phosphate foods. I think one of the hardest things about those nutrition questions, guys, is that does that have phosphate or does that not have phosphate? It's very tough, and I feel that. You also can give diuretics. Hemodialysis is usually a big one. Also, you can give phosphate binders, not the phosphate medication. Sorry. Anyway, hypophosphatemia, on the other hand, is just the opposite, which is hyperkalemia, hyperpotassium calcemia. So yeah, as long as you know calcium, you'll kind of know what phosphate is, because it just pairs up with it. Is there any questions about that? Concerns? I honestly recommend knowing the relationships between them, because it's gonna help you out, especially with us. Go ahead.
No question.
Perfect. Thank you, Crystal. With that said, guys, we're gonna now talk about different things. Feel free to let me know if you have any questions. So let's see what's on the next list. Transurethral resection prostatectomy. Honestly, when I first saw this word, guys, I would kind of try to, like the night before, I try to prepare to see what that, to help you guys out the best. With that said, that ectomy, when you read the first word, it will tell you everything you need to know. So when talking about transurethra, you know what the urethra is. When we talk resection, usually probably talking about surgical procedures, and prostate, we talk about only occurring in males. So we're talking about a prostate condition. Ectomy usually means removal up, okay? And so we talk about transurethral resection prostatectomy. We're talking about benign prostate hyperplasty, which just means your prostate's growing. And as we know, the older a guy gets, the more risks they will have for a prostate enlargement. Okay, it's just that. That's why after the age of 50, I believe, that they'll start to do a prostate exam just to make sure that the prostate is not growing. Okay, if it is growing, then it's going to cause intense pain, or it's going to be really irritable. Either or, what we do is one of these procedures. This procedure is consisted of a sorry, let me go through my book. I kept the page open just to make sure that you guys get it. So once again, this is a procedure in which we insert like a needle or lead thing, a catheter into the urethra. Obviously, we provide pain medication because that will hurt. So we provide pain medication before we even do that, guys. But we basically push it in and try to make usually they have a balloon. So you insert that balloon and it just tries to open it, okay? What happens in the benign prostate is that it grows too much and makes the lumen small, okay? Your urethra lumens become smaller, okay? Obviously, making it smaller will cause irritation or obstruction. Majority of the time, it causes obstruction, so you're looking at like lack of urine, which is called anuria. Also, it's going to be painful to urinate because of the fact that you're trying to push through these walls that are not supposed to be there. And so when you talk about transresection, we want to put a balloon in there, kind of dilate it. It's kind of like a catheter where we also have to dilate it just to make sure that we can push it through, okay? With that said, cool. Is there any questions about what a transurethral ectomy is or prostatectomy is? If not, I'm going to move on to what diagnosis requires TURP as treatment. I think we already know that. It's benign, benign prostate hyperplasty, okay? Hyperplasty means a large growth. And so, yeah, that's pretty much it. And so now pre-operative nursing responsibilities. If you guys know your pre-op standards, you'll be pretty much fine. Like, for example, we always give antibiotics. Make sure you're monitoring them for fever. If there's a fever and there's infection, we are not doing the surgery, okay? Remember, your key signs and symptoms of infection, redness, fever, elevated white blood cells. Those are something we're going to be monitoring, okay? Other pre-op procedures that we have to do, even though this has a low risk for bleeding, we also need to do red blood cells just in case we go into, we technically measure hemoglobin hematocrit rather than red blood cells. But with that said, if it's low, we might want to prepare for a blood transfusion or increase his fluids or let the doctor know, et cetera, et cetera. This tends to be a low risk bleeding procedure. However, there is still risk for bleeding, which is why in pre-op, we always have to make sure we're monitoring the labs. If you're going to be that med-surg nurse, guys, make sure that you guys are ahead of that game, okay? You don't want to send a patient into surgery with low blood, okay? With that said, other things that we do is going to be related to inserting a urinary catheter, just so they can pee, et cetera, et cetera. Also, it says here that you can give a lidocaine gel, okay? Obviously, the purpose of lidocaine is anesthetic. In this case, also, it's actually used for a lubricant. So, so it's going to help move the thing into the urethra. It's very interesting. But lidocaine helps to reduce the pain, okay? Because it's going to be very painful. I'm not going to lie. Okay, and so once again, make sure that this is for mental health. I don't think you're going to focus on a lot on these questions, but mental health, guys, make sure that you guys are asking questions, asking the patient, are they okay? Will they be okay with this procedure, et cetera, et cetera. Informed consent, make sure they have informed consent, guys. We already talked about informed consent last week. Everything kind of just rolls over. I believe in y'all. But with that said, make sure that you guys tell them about retrograde ejaculation, which just means that if they ejaculate, the sperm is going to go up the bladder and it's going to reduce their pleasure, but at the same time, it's expected. Okay, it's not like it's not going to be expected. So let them know about that. With that said, that's it for pre-op. Okay, so if you guys do all your pre-op medications, everything in pre-op, the same thing in post-op. In post-op, we're looking for main complex. Okay, Megan.
Oh,
Yep.
sorry, I didn't mean to cut you off.
Oh,
But what was the antibiotic called? That's for like just kind of like a universal antibiotic to give for pre-op.
oh, I don't know. I want to no, that's not.
A broad spectrum antibiotic, as long as they're not allergic to it.
Yeah, exactly.
Oh,
Usually it's
okay.
just an antibiotic. Yeah. I wish there was a one that's specific to it, but we usually don't have one.
Oh, okay. So it's just kind of known as like a broad spectrum one. There's no like specific name for it.
Yeah, no, yeah. Usually for any pre-op procedure, we do antibiotic prophylactically for 1 hour at least, if not 30 minutes. So then they can get the maximum benefits of it.
Got it. Thank you.
Yeah. Sorry, there's no specific one. Anyway, moving on from post-op, guys. So once again, we're monitoring for bleeding, guys. That's number one. Okay. And then we're monitoring for infection, of course, and we're monitoring for clots. The thing with this procedure is that it has a lot of clot risk. So what you're going to see at first is that you're going to see a lot of clots coming out from, if you're monitoring the urinary catheter, you're going to see a lot of clots coming out, blood clots coming out. That's normal within the first few hours. Let me see, what was it? First 24 to 36 hours, guys. So within the first 24 to 36 hours, you're going to see clots. That's kind of normal. But after that, what you should see is pink tinge urine. So it's just going to be more pink-ish, but not necessarily a thing for you to concern. However, it's after 36 hours and they're bleeding rapidly, like you can see red, like red blood. That's something that you guys need to call the doctor about, because that means they're going to have some type of hypovolemia because you're losing so much blood. Okay. In the sense of, I believe that there's also, make sure that they, in post-op, teach them about not lifting heavy stuff. If it requires abdominal moving up and down on the abdomen, or in abdominal strain, try not to do those activities. Okay, we're looking at like house cleaning chores, like cleaning dishes. You're not going to use your abdomen as much, but for example, vacuuming, that's going to be a little bit more intense of the core. So those are some things you need to educate them about. With that said, Kegel exercises, guys. Kegel exercises is another big thing. It's basically you're practicing pelvic floor things. It says here that you can reference the chapter 45 on table 18. You'll be able to find the answer for that one. Kegel exercises are very important, but it really helps with urinary and pregnant women a lot. With that said, in the sense of, she also asked you guys about continuous bladder irrigation, nursing responsibilities. There's a chart on page 1261 that says patient nursing management related to patient receiving bladder irrigation. Feel free to look at that, guys. It's about like monitoring for blood, bleeding, and clots, making sure the catheter is patent, okay? Making sure that you're irrigating, manual irrigating if bladder spasms or decreased output. So if you notice that there's a decreased output within the last hour, remember your normal, do you guys know your normal urinary output level?
30.
Yeah, 30 milliliters per hour, perfect. And so if it's not that normal, that means you kind of need to look at the patients to see what's going on. Make sure you guys are using that bladder scanner to see, how much water is in the blood, how much water is in the bladder. And so that's really why we want to do the irrigation in the first place. And then we have give antispasmodics or anesthesics, just anesthesia for pain, antispasmodics prevent spasming, monitor catheter and drainage, patient Kegel exercises, and patient discharge. Pretty much, if they have an indwelling catheter. And we know how to take care of an indwelling catheter. The only thing is, if they have diabetes, guys, make sure you monitor them even more, okay? Because catheters increase UTIs. Yes.
Professor also mentioned that if you see that you can't unblock whatever's keeping the outflow, to remove the catheter and notify the doctor.
Yes. Yes, definitely do that, guys, because That blockage right there means that there's something else that's wrong, and we're not responsible for that. Cool. Moving on. Pain management, guys. I feel like pain management is just like overall, we talk about a lot of pain medications. I think your pharmacology class talks about pain medications like opiates. We talk about ibuprofen, which NSAIDs, and other anesthesiology within that term. Medical management, that's the medical management. On the other hand, we have the non-pharmacological evidence that we do, like for example, distraction, meditation, complementary therapies. That's pretty much it for the pain management. It's talking about pain management for this patient. It was talking about pain management for this patient, anesthesia. You usually give them pain medication. Lidocaine was the one that we talked about for the procedure itself. And so we can also do, stool softeners. In the case of that, you can also do opioid suppositories, okay? Which then helps to relieve the pain and all that good stuff. Yeah. Cool. Know that this can also cause incontinence, guys. So within it takes about, it says here 12 months for it to improve. So incontinence is expected. So make sure that you assess their emotions regarding that. Teach them how to use, I think it's called pads here. It's like a type of pad that you use. A penile clamp, that's what it says, or incontinent brief or boxers, just so you can avoid that incident. Cool. Any question about transurethra resection prostatectomy? No, yes, maybe so. Perfect. Okay. So incontinence. When we talk about incontinence, guys, what is incontinence? I'm so sorry. Can somebody repeat?
Not being able to go. Oh, there's 4 different types. So incontinence, having issues with urinating.
Can you repeat? I'm so sorry, Crystal. Having
issues with urinating?
Yes, guys, correct. Exactly. Having the inability to control your urinating. That's really the key word, inability to control it. So therefore, you kind of pee all over the place. It's also it's one of the number 1 reasons why people get admitted to skilled nursing facilities, okay? Because they aren't able to control it. And so that's actually one of the reasons, which is very sad. But it's something that we have to consider. But we have different types that you guys have to know. There's more types in this, but I think you guys just kind of need to know what is it and what are your key signs and symptoms for it, as well as some treatment options for it. Majority for your incontinence, always the best way to treat it is going to be doing your urinary calendar, or kind of telling them like, oh, hold it for 2 hours and we'll be able to go it. Hold it until you're able to hold it, and then I'll take you. And that's going to help them build that muscle again. So a lot of them are going to talk about muscles. But when we talk about urgent continence is number 1 seen in UTIs. If you have UTI, you're going to have an urgent continence. That's it. It means that you need to go now, no matter what. And so you're going to be going rapidly to the restroom, even if it's just for a little bit of pee. It's just you have to go now. So urgent continence tends to be that. It's just you need to go now. There's an increased risk for fall risk, guys, and also discomfort, of course. And so majority of the time, we usually treat these with antibiotics. It usually doesn't come in any other sense other than UTIs, but they usually come for that. So urgent continence commonly associated with UTIs. Increased risk for falls, so we have to do fall precautions. Make sure you guys are getting antibiotics or doing some collection, because it's usually caused by that stuff, okay? Next, we talk about reflex incontinence. I'm just gonna Google this for a hot second because I totally forgot what this occurs when the bladder contracts and urine leaks without any warning or urge. Oh, okay, that's interesting. So this is when you have the lack of neurological reflexes down there. So you can't feel the sensation to basically pee. That's according to Google, of course. And so then you're gonna basically just go out. So with that said, the best way to treat these patients is just to do that 2-hour rounding, or that hour rounding where you're asking, let me take you to the restroom, so then you don't have to pee on yourself. Because, guys, cleaning up a patient on a bed who is immobile is horrible. And so doing your hourly round will save you from having to do that. So reflex incontinence is definitely just trying to make sure that they recognize it a little bit more, and also just doing the hourly stuff or 2 hours every 2 hours kind of thing. It just really depends. Just at least help them empty their bladder so then they don't have the necessarily to pee, okay? Because the bladder will contract, but the patient won't feel that they need to pee. And so doing the hourly round, basically encouraging to, pee frequently in the restroom, okay? So every hour, make sure you go to the restroom, pee, and then so you won't wet yourself. That's really one of the best treatments for reflex incontinence. So once again, reflex is all about the nerve. You can't feel the need to pee, okay? Urge is all about the need to pee right then and now. And so they're pretty much a little bit the opposite of each other, okay? Stress incontinence. Commonly, frequently, pregnant patients, obese patients, those are your 2 most common patients associated with stress incontinence. What do I mean by stress incontinence? If you do some maneuver, or for example, you're just sitting there and you laugh a little bit, that's going to cause something called stress incontinence. You put more pressure onto your bladder, which then causes your bladder to kind of like contract a little bit, and you release a little bit of pee. It's very common in obesity and pregnancy women because, once again, pregnant women have the fetus inside of them. And so the fetus, like when the woman laughs or if the fetus kicks, then it's just going to cause the bladder to basically open and you release a little bit of pee. It's natural in pregnant women. Obesity is the same thing. You have this abnormally large pressure on your abdomen. And so if you laugh a little bit, or if you do anything related to sneezing, even sneezing can cause it, then the pressure increases there, and then it causes your bladder to basically contract, okay? With stress incontinence, it tends to be little dribbles. It tends to not be a lot because the bladder then gains control. But stress incontinence, the best way to treat it is basically, in obesity case, make sure you manage your eating healthier. With stress incontinence for fetus, obviously, you have to do all the procedures afterwards because you can't really stop the fetus from kicking you. So, so it's basically going to occur after pregnancy. So a lot of the teaching for pregnant women related to stress incontinence is just to make sure that, make sure you can wear a pad. So just in case the baby like kicks you, you might have a little bit of dribble, let them know it's normal, all that good stuff, okay? So that's related to stress incontinence. Cool? Now, on to the last one is called functional incontinence. Functional incontinence is related to really 100% dementia. It's actually related to a lot of neurological defects, okay? Dementia tends to be the biggest one, and functional just means that you're not able to recall, especially not able to know that you're supposed to use the restroom, okay? A big thing is, inability to reach the toilet in time. That's functional, it's just functional, inability to reach the toilet in time, okay? And it's usually caused by dementia or a lot of Alzheimer's diseases or anything physical, okay? When we talk about physical, like for example, if your patient is in restraints, they can't physically go to the restroom if they need to use the restroom. So functional is inability to reach it. For a patient with dementia and Alzheimer's, they could probably forget that they need to use the restroom when they're walking outside the door and they're like, oh, you know what I need to use today? A, B, and C. When 5 minutes ago, they were like, I need to use the restroom. That's called functional incontinence, okay? Best way to treat it is, once again, make sure that you're doing those hourly rounds and making sure that, keeping them on a tight schedule, making sure that, okay, we're gonna try to retrain your bladder, okay? Yeah, I think that is it. Obviously, you wanna avoid unnecessary catheterization. Guys, if your patient is incontinent, never, I repeat, never give them a catheter, okay? The reason why, there's so much increased risk for infection. As you guys know, CAUTI, if you guys don't know CAUTI, guys, it's a catheter-associated UTI. And it's a key term for everybody in the medical field to use. And we used to do it all the time, by the way, back in the olden days. But nowadays, we don't want to do it. We only reserve it for a certain group of people, okay? Especially in diabetic patients, guys. As you guys know, a lot of geriatric population are diabetic because of type 2 diabetes. We don't want to give them a catheter because it's going to increase more UTIs. So even if they have incontinence, make sure you clean them up. Make sure you treat them with dignity. Make sure you do all the hourly rounds that you need to. And do not, for the reason of incontinence, do not use a catheter. For any other reason, for example, surgery, yeah, okay, we can use that. But for example, don't do it for incontinence. That's one of the biggest things. Never do that. Asectomy, make sure you're wiping from front to back, UTI stuff, you know. Yeah. And so, yeah, that's it for urinary incontinence or incontinence in general. Also a tip, guys, make sure you put in the condom. Like if you guys are going to change the bed and put the condom on, for example, a condom catheter on, guys, make sure you do the catheter first. You don't want to clean the bed 3 times because your patient wet themselves. Yes, I learned from past experience. Just do the catheter first, clean the bed later. Okay, so next we're gonna talk about ecology and treatment for each. Oh yeah, cool. We talked about that. Cool. Any questions? Anyway, we're talking about renal terminology, guys. This is the last part that you guys kind of told me. Aurina. Anything with A in front of it means the lack of. Okay, so for example, ahendonia means lack of pleasure. Apneic means that you're not breathing. Anything with an A in front of it in a medical terminology means lack of something. So this means lack of urine. Cool. Poly. Anything that has the word poly root word means that there's many. So that means you're peeing a lot. Okay, you're gonna see polyuria with a lot of these conditions, especially for urge incontinence, but not to the point where it's just like it talks about you trying to pee a lot. And then you'll see a lot with electrolyte imbalances, like we talked about sodium, like hypernatremia. You're gonna try to pee a lot just because your body's trying to get rid of all that sodium, like we talked about. And then we talked about diabetes, polyuria. It's going to be a key sign and symptom because glucose is a large molecule. It's going to pull out a lot of water. Olyuria, okay, means infrequent. You're going to talk about oligomenorrhea. It's the same thing, which means like infrequent. You don't do it a lot. I wish there was a number for it. Let me see if there's like a number for olyuria, like how many days you need to get. It's a normally small amount of urine. So yes. So this talks about the amount of urine, okay? So when we talk about olyuria, it means the small amount of urine, okay? Not necessarily the frequency that you need to go. It just talks about small amount of urine. And so with oligomenorrhea, it means a small amount of menstrual bleeding. And so, yeah, that's pretty much that one. And last but not least, nocturia. Noct meaning nighttime and nighttime. Uria, which is occurring nocturia. Nocturia is actually going to be common with your urge intestines, guys. What happens is that during the night, you have to go to pee, okay? Disrupted sleep, as we know, will cause more intense stress and more intense pain. And so that's why nocturia is going to be closely resembling urge incontinence, okay? UTIs, nocturias are definitely key sign and symptom. Awesome. Is there any other things you guys want me to talk about? I know, same. Sometimes I just read over. I'm just like...
Actually, I do. I was reading, looking for the BUN, the GFR, and the creatinine values.
Ooh, I got you.
I would get exactly the amounts. I would just get like greater than 120, extremely high.
Extremely high. Oh, but let me. It's okay if I give you the normal values.
Yes, please.
Perfect. Okay, so guys, so with BUN, creatinine, and GFR, those are your key signs and symptoms for kidneys, okay? If you want to measure your kidneys, BUN, creatinine, and GFR. GFR is number 1. It's just super high up there. It will tell you how it functions. Your normal levels outside the hospital is going to be 90. Your normal levels inside the hospital is going to be at least 60, okay? And the reason why is the hospital is really good at damaging your kidneys. As we know, there's a lot of medications that damage your kidneys, like vancomycin. That's definitely like kidney killer. And we talk about TB. Oh, I don't know if you guys talked about TB yet. But TB, that's another medication list that's very heavy on the kidney, okay? And that's going to cause it. Metformin's another medication that's actually hard on kidneys. Outside the hospital, it's not hard on kidneys, but inside the hospital, it's very hard. So that's why in the hospital, it has to be a little bit lower. But as you guys know, you'll learn from chronic kidney failure that once you hit 60, it means that you're definitely like going to have chronic kidney failure. So GFR is your key sign, okay? So anything outside the hospital, it's going to be 90. Inside the hospital, 60, okay? That's your glomerulus filtration rate in case anybody doesn't know what GFR stands for, okay? If the rate is higher than 90, you all good. If you're at 90, a little bit for concern. If you're in the hospital, you're at 60, it's aight. But if you are lower than 60, it means let's try to fix what your kidney's going through, okay? With that said, we have BUN. The next one will be creatinine. Creatinine is the next level, okay? It's the reason for that is creatinine is from your muscle. Okay, it's a byproduct of your muscle product, and basically when your muscle contracts or anything like that, it basically destroys the destruction of muscles because we know that cells replace themselves all the time. Creatinine levels is specific to the kidneys because it's the only thing that gets filtered by the kidneys. And so if you have a normally high creatinine levels, guys, it's going to be related to kidney failure. Okay, when we talk about creatinine levels, oh my god, I can't believe I got it. Anyway, there's for males and females. I try to memorize both. But once again, in textbook and testing, it's usually only one, one level, and it's very interesting. But once again, creatinine in males is 0.7 to 1.3. Creatinine in females is 0.5 to 1.1. With that said, most people, especially in the ATI book, even though they talk about the differences within female and male, here you go. This is the normal for your creatinine level. Majority of people tend to go between the ranges of 0.5 to 1.3. Those are usually normal ranges, once again, just because you take the lowest number and the highest number. If you guys want to memorize one number, that tends to be good. Or they tend to take the female number and they just do 0.5 to 1.3. The only thing is that they usually use very high numbers or very low numbers. They don't try to do it within that area and range, just because we know there's differences with every system, with every school, with every textbook. And so I wish there was an easier way to be like, this is your normal, but there's not. So 0.5 to 1.3 is usually normal, but for males, 0.7 to 1.3, and then for females, 0.5 to 1.1. Okay. With your BUN, it's not as specific as creatinine, nor is it as specific as GFR, but because BUN can actually be caused by a lot of things. BUN is just blood uric nitrogen. That's your normal levels. For me, I memorized it as 9 to 20. That's how I memorized it. Some people memorize it 10 to 20. And I've seen it as high as like 23, but never higher than that. But once again, I memorized it 9 to 20. This is the easiest way. BUN is a good way to measure it. Well, the thing is, you can't confirm a diagnosis for kidney failure without the GFR. So those are your normal levels. Does that help you, Crystal?
Yes, thank you.
Of course. Perfect. Awesome. In case of, she asked questions about end-stage renal failure. If your GFR reaches 15, it means your kidney's about to die. Awesome. So Annette here says, urothesis. I'm going to take out the limb. Thesis usually means stone. So if you guys have the ending of it, it's stone. So it's good. It talks about kidney stones, guys. So kidney stones is a big risk factor. We're talking about definitely diet. If you guys are eating like very urine diets, calcium diets, high calcium diet, guys, those are going to be the ones that are going to cause your kidney stones. And in terms of diets, of course. In the sense of, let me see in the book, what does it say? Because I think she teaches from the book. I actually never read the book while I was intro to med-surg. I only read it for like certain material, like tables and everything like that, but I've never like sat down and read it. Because I used the ATI book when I was at level. But let's see. Kidney stones, treatment options. Usually treatment options, if it's small enough, they're gonna let you pass it. And the best way to pass it is to increase a lot of fluid. So they're gonna give a lot of fluid to the patient just to make sure they can pass the kidney stones. It's gonna be very painful. I'm gonna be honest. It's gonna be super painful. And so we gotta make sure that we're giving them, what's the word? Pain medication. Woo, all over the place. Okay. The thing is, if you have urethritis, you also want to make sure that no other urine's getting trapped. If it's getting trapped, guys, it's an indication that it could be an indication for UTIs. Okay. Anything that gets trapped, anything that sees stasis in the body, it can lead to a lot of complications. In this sense, reduce outflow, increase risk for UTI. It's always painful. It's really the only reason why you would complain for it. And so make sure you have pain medication. Yeah, I'm trying to figure out indwelling catheters, blah, 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 blah. Underlying cause, et cetera, et cetera. Okay. Does anybody want to tell me other risk factors related to that? Feel free to share. I'm trying to figure out the procedure where you can, it's kind of like a sound where they break the stones in there, so it makes it easier. I'm just trying to find the name for that procedure right now.
Is it lithotripsy or something like that?
Yes,
Is it
I don't know how to spell it, but I think that's something in
I have
that
it
context.
on here. It's L-Y. Lithotripsy. Lithotripsy.
Thank you.
Ooh, thanks. Thank you, guys. Thank you. Yeah, no, you can also do that if it's super big. So then you can just break it down. They really just don't want to be invasive in that area. And so that's why they usually do that procedure to try to make you pass it. We just want to pass it. Okay. Yes, prevented hyperglycemia and dehydration. Yes, hyperglycemia and dehydration can lead to that. Dehydration, we know why, because of the fact that if you're not passing it, then anything that stays stasis will cause a problem. Okay, that's really how I memorize that one. Okay, let's see, 25. Wow, okay. Yeah, I hope that helps you guys out. Yeah, hopefully. Okay, information, etc., etc.
You always like, it was awesome. I felt so much better going into last week.
Oh, that's good. Okay, I'm really happy and helpful. So yes, other than the book, they also said you can also do warm sitz bath. You can do bacterial. If you have an infection there, guys, make sure you guys use bacteria. Anything with infection, antibiotics. Oh, sorry, bacteria. If it's caused by bacteria, antibiotics. If it's caused by viral, then it's antiviral. Well, once again, not all antivirals work for all virals. Yeah, let's see. Cytosotomy. Sotomy means that it's a scopy. So if a scopy means that you see through something, and so you're visualizing the cystic or the bladder. So you're gonna try to visualize bladder and insert a camera via the bladder. Yeah, and then we talked about benign hyperoplasty. Wow. Okay, cool. Awesome. Clinical manifestations, guys. Once again, it could be irritative or obstructive. Irritated means that you will basically have redness in that area, and so you're gonna be irritable, you're gonna be peeing a lot, dysuria, pain. Really, that's one of the key signs and symptoms. And then the other side of it is going to be obstructive, where you don't pee at all, you're having intense pain, and even if you pee, it's like very small in amounts. Okay, so those are the two types of benign plastic hyperplasties. Bladder assessment, palpation, and bladder scan. Palpation. So the thing is, if palpating the bladder, and you want to make sure your patient peed first, okay? Especially when you're palpating the bladder, okay? The reason why is that if you palpate the bladder and they have a weak sphincter, it's just, they're gonna pee all over the place. But in the sense of when we don't palpate it, is usually in the sense of, well, we palpate it just to see if it's hard. If it's hard, that means the palpation, that means we're required to do the bladder scanner to see how much is there. And so the bladder scanner is used to basically make sure you use your jelly and just to see how much fluid is in there. I believe, I would say, oh, there was a comfortable. There's like a word amount that like your body becomes uncomfortable. How much fluid is there? How much fluid does your bladder hold? Yeah, so a healthy bladder can hold up to 300 to 4 milliliters of urine. Cool. Yeah, so it can hold up to, so when you become uncomfortable, it's about 300 to 400. And so that's when that's going to be when you kind of like, oh, okay, I need to use the restroom now. But if it overflows that, it usually can hold up to 800 milliliters, I'm so sorry. 800 milliliters, which is kind of a little bit dangerous, but that's why we have to make sure that we are palpating the bladder. Make sure it's like very careful, or you can do the bladder scan. Majority of nurses who work on like post-op unit, they like to do the bladder scan so then they don't cause the patient to pee. If your patient does have like a catheter, you can just palpate it and like just pee in the catheter. But yes, bowel prep contradictions for kidney compromised patients. Bowel prep. What does she mean by bowel prep? Let's see. Bowel meaning the contraindicated for kidney compromised patients. Are we talking about enema? No, enema doesn't do that. Did anybody know?
Yeah, she's talking about that.
Magnesium nitrate enema.
Problem patients,
Oh.
magnesium citrate and fleet enema.
Oh my god, cool. So they were talking about enema. Enema. Perfect. Awesome. I feel like the reason for that is all about kidney and restriction. But yes, Brittany, do you want to elaborate on the bowel prep for it?
That was Crystal.
Oh, Crystal. Yes, do you want to elaborate on the bowel prep?
Who, me? I just said it. Whatever the notes I took was, she mentioned that we couldn't use that magnesium citrate and the fleet enema with patients that had kidneys because of issues with kidneys, not being able to.
Oh, get rid of the excess fluid.
Wasn't it the normal saline lactated ringer too?
No, not for the cannot use. I didn't take that down, but if you did, girl, let me know now.
Go ahead, feel free to. Yeah, honestly, yeah, I feel like you're correct. Well, so what the body's gonna do is just try to take in as much liquid as they can, or all the electrolytes within that medication of enema. And if the kidneys cannot excrete it, then the kidneys gonna keep it within it. And so that can be toxic to our patient, and that can cause a lot of electrolyte complications that we'll know about later, or fluid complications too. Yeah. Other than that, I think we covered a good amount, guys. I'm so proud of us. Other than that, is there any big questions you guys want to cover or anything like that? Yes, no, maybe so. I'm more than happy to answer questions.
I think, in my opinion, it was well covered. So I don't have any questions. I'm not sure about my classmates though.
Go ahead, feel free to let me know. If not, I think you guys are all free to go today. Yay, thank you, Panette. Of course, thank you, Soraya. Oh, thank you, Crystal. I'm hoping this helps you guys out. Oh. Honestly, just critical thinking. I'm trying to help you guys critical think the best you guys can. That's going to save your license in the end anyway. Good. Okay, good. That's what I need. That's what I want you guys to do. We appreciate your reviews. Aw, thanks. Even though sometimes it can be disorganized, I try to keep it together.
Thank you so much. Have a great afternoon and enjoy the sun if you get out.
Of course. Honestly, it should. Vitamin D, guys. Vitamin D, that calcium.
Bye. Let me go
Bye.
sit
Thank
now.
you. Make sure you guys can sign in, okay? Let me know if you guys can sign in.
Thank you again, Jackson. I appreciate it.
Of course. I'll do my best to help.
All right,
Where were you going today,
Saturday.
Megan?
Huh?
Where were you going today?
Oh, yeah, sorry. I'm actually out right now. I went to get boba and Fat Sal's. So,
I don't know what it is.
Yeah, just went out to get food, and I was still eating food. That's why I was so unprepared to say the values. I was like trying to talk, but I was like, oh wait, I have myself on mute, and then I was like, wait. Sorry.
All good, homie. All good.
Yeah. Okay. Take care. I'll see you
Thank
Saturday.
Oh, Tom. Tom, did you sign in? I just have curiosity. If not, here you go. Feel free to time in. Do you have any other questions for me? Yes, no, Lisa? Yeah, so feel free to let me know. If not, I guess I'm going to head out right now. Let me just put, I think Tom did it.